So this video today is kind of explaining my mental model or the thought processes I have around traumatic instability, right? And we think of instability, I think of it in kind of two terms or two ways. There's traumatic and atraumatic. And so traumatic is essentially you had a severe injury to your shoulder where you've dislocated the joint, right? And either you're an athlete and it was put back in on the field, or you had to go to the emergency room and someone had to put your shoulder back in the socket. So that's traumatic instability. Or the other situation is you had an injury and you felt your shoulder slip in and out of the socket, right? And so in either of those instances, the shoulder joint is incredibly complex, but we try to simplify things. You've got this ball and socket joint here, right? So you've got this golf ball on a tee, right? And you've got the rotator cuff, which sits on the outside, and it's a group of 4 muscles that help stabilize. You've got the ball and socket joint, right, that has a slight concavity to it that adds stability. And then around it, you have the labrum and the capsule, which is deep to the rotator cuff. And that is really one of the main stabilizers. So when you traumatically dislocate your shoulder, what you do essentially is permanently stretch out the labrum, right? You have to do that in order for the shoulder to come out of the socket. So anytime the shoulder comes out of the socket and then goes back in, a permanent change has occurred to the shoulder. Now, people of all walks of life get shoulder dislocations. When you're younger, or younger patients, and I would say 25 to 30 and younger, the problem that we face typically with those patients is that the shoulder continues to want to come out of the socket, right? And very often, we look at, young contact athletes would be one. If you're a young contact athlete and you have a shoulder dislocation and you go back to playing contact sports, your chances of the shoulder continuing to come out or be unstable are upwards of 95%. So we typically recommend an operation in that setting, which is going in and repairing the tears to stabilize the shoulder. It's similar to tearing the ACL in your knee. That creates a lot of instability in the knee. And so you don't have to have your ACL fixed, you don't have to have your labrum repaired, but if you want to go back to playing sports at a high level, often you do. Again, if you're also very active and you're doing a lot of heavy lifting, or your recreational activities require a lot of stress on your shoulder, it may not come out of the socket completely, but you will have this feeling of instability or a sensation that the shoulder is not stable very commonly. So in those patients, we typically recommend doing an operation. Patients in their later 30s, early 40s and up, you can dislocate your shoulder, and often we'll put it back in the socket. And as long as you're tolerant of that feeling and you're not doing a lot of very, very high demand activities, those patients can actually be treated fairly commonly without an operation. And then sometimes in older patients, they tear their rotator cuff when they dislocate. And when that happens, we recommend repairing it because those patients tend to not be very happy without an operation. So really 3 tiers there. You've got the younger patients that are dislocating and wanting to go back to sports. You've got the mid-range where they're maybe not doing high intense activity, or they're not playing high school football, but they're still doing a lot of labor or working with their shoulders and it's unstable. And then you've got the older patients that may tear their rotator cuff, and then older patients who dislocate their shoulder and don't tear their rotator cuff, they actually do quite well without an operation because they're just not as high demand. So it really just depends on where you're at in life in terms of what we decide to do. If the shoulder continues to be unstable, right? So if you've had one dislocation and then you have another, each subsequent dislocation becomes easier and easier to occur, right? It's kind of like greasing the track, so to speak. And then you could also start to lose bone in the shoulder, right? Which then increases the level of complexity of the operations that we have to do to repair this. The surgeries that we do to repair this are typically arthroscopic, labral repairs. We can add other things sometimes to the labral repair to increase the strength. We do arthroscopic bone block procedures now, which is something that's pretty exciting. That's kind of a new advancement in shoulder arthroscopy that we're doing now in our practice, and the results are very good in the patients who have bone loss. So a lot of things that we can do to treat this, but if just kind of understand, once that shoulder comes out of the socket, it's never going to be quite the same as it was before, because you have to permanently stretch out the shoulder for that to happen. But we see this a lot, and plenty of ways to treat it and make sure that whatever we need to do to get you a stable shoulder, we're going to do. Thank you very much.